Hey, it's Dr. Blake Williamson from Williamson Eye Center in Baton Rouge, and I'm excited to be here today shooting a video for interventional mindset. And this quarter they're talking about presbyopia. Moving the needle in presbyopia treatment is something that they're really focusing on. And specifically, my topic was, I've never done one. What are some practical approaches to getting started with presbyopia correcting IOLs? So for those folks who have never done this or have done it sparingly and are looking to do more of these, I think there's really four key areas that you need to focus on. It's picking the right patients, screening appropriately, mastering the presbyopic IOL conversation, and then performing great surgery. So for picking the right patients, I think when you're getting started, it's important to go for the low-hanging fruit. So certainly, nobody who's post-refractive, don't look for post-RK and post-LASIK and all that stuff. We have a lot of advanced lenses now, and modern lenses, you can get away with that a lot of times, but not when you're starting. So just pick people who have virgin corneas. Also, no retinal pathologies either. So we want to make sure nobody has an ERM or subtle AMD, stuff like that, that again, you can get away with modern presbyopic IOLs. Wouldn't recommend doing that for your first few cases. A healthy ocular surface is key. So want to make sure that you manage the dry eye and setting the right expectations. It's very important that when you're talking to these patients that you choose people who are willing to have some of the dysphotopsias associated with even our more modern presbyopic IOLs. And then lastly, I would tell you, make your first few cases hyperopes. So with a hyperopic patient, they don't see very well far away or up close. So if you get that cataract age patient who's also hyperopic, chances are you're going to make this patient very, very happy. The second thing is screening appropriately. So very important that you are performing the topography on all these patients. Also with your biometry, it'd be great if the Ks in your biometry match your topography. That's very important, especially whenever you're managing astigmatism. You want to get an OCT MAC on all of these patients. That's very important. Corneal staining to pick up subtle EBMD. Remember to lift the lid to look for Salzmann's nodules and EBMD and dry eye that may be hanging out underneath the lid. And then lastly, point of care testing has been good. For me in my practice, a lot of times the dry eye can be subtle in terms of corneal staining. So having osmolarity and MMP9 has been great for me. The third bucket is the conversation. So many people struggle with talking about these lenses. And again, the most important thing is to set the appropriate expectations. You want to undersell dramatically so that you can over-deliver magically. A lot of people know undersell, over-deliver, but they have a hard time actually following through on that. So, I'll give you some pearls for what I do. One of the very first things that I say, I tell every patient that nothing I'm going to do for you is as good as what God gave you. I can't make you 20 years old again, right? They understand that. It automatically lets them, lets it sink in that there's going to be some give and take. There's going to be some compromise. Another thing I say when talking about presbyopic IOLs is no rings, no read, like no pain, no gain. It's not what you tell patients, it's what they remember. So a lot of times you can be describing these elaborate, starbursts and halos, and it's in one ear and out the other. But if you tell the patient no rings, no read, like no pain, no gain, they tend to remember that, and afterwards they remind me that I told them that. So with regards to reading glasses, if they're choosing a presbyopic IOL, they want to be out of readers, right? But it's important that you explain to them that you cannot guarantee they're going to be out of reading glasses. The phrase that I always use is, this is not about ridding the world of reading glasses. It's just about dramatically reducing your need for them, which I think that we can do with modern technologies. Oftentimes they accept that, but they want to know what can they read. So what if they're going to pay extra money to have a presbyopic solution, what could they read without reading glasses? So what I do is I pull out the near card and I show them J5 and J3, which is more than halfway down the reading card. It's not micro vision, but it's really good near vision. And I tell them, hey, I'd be very, very surprised if we couldn't get you somewhere in this J5, J3 range, knowing full well that over 95% of them will be J3 or even better, J2, J1, some are J1 plus, depending on the lens technology that you're choosing. So that's always good to over-deliver in terms of reading glasses. And then the last thing with regards to the conversation is is understanding the financial piece. A lot of doctors, they don't feel comfortable talking about finances. And this is something that you're going to have to kind of get over if you're going to be launching this in your practice. Unless you have an amazing lens counselor who can help you with this, oftentimes we're doing it on our own. And sometimes patients prefer that anyway. It's a little bit more personal. So, I think that, there's two things that patients want to know when they're in to see you for a cataract evaluation. Number one, is this going to hurt? Am I going to be okay? And number two, what's it going to cost? So I just address that in the room. I don't get into the nitty-gritty details of financing and all that stuff, but I do have a general idea of what it costs out of pocket after insurance, and I have a general idea of what it costs if you were to finance it over time. I simply let patients know this, and then I let them know that my counselor will be in after me to kind of go over the finite details of that. And I think that that's very, very helpful. That way I'm only sending patients to my counselor who understand there's going to be some out of pocket, understand kind of what it's going to be, and that way I'm not sending her people who don't have the available income to do that, and makes her feel like a failure, right? So you want to set her up for success. I only send patients who I've had the pre-conversation with. So, and then in making sure you have financing available is very, very important. There's a bunch of different people out there that are doing this, Care Credit and Green Sky, also Alpheon Credit and others. So the last thing we'll talk about is should be the easiest thing. You've already screened the patient, you've picked the right patient, you've had that conversation with the patient. Now it's just time for you to do what you do, which is perform perfect surgery. So you want to take it to the hoop, you want to take it hard, you want to do a great job with this patient. Really making sure that you have a nice, well-centered 5mm capsulorhexis to overlay the optic, which is usually going to be 6mm. You want to avoid any tilt or anything like that because that can induce astigmatism. It can cause coma. I like to center the corneal light reflex right there on the central button. If you do have to nudge the IOL a little bit, I would do so nasally. And then being sure to remove all the posterior viscoelastic is especially important, especially in your toric presbyopia IOLs. Getting a good wound seal is very, very important as well. You want that to be watertight. We know that if there's going to be any movement in the IOL, usually it's in the first 24 hours and really probably the first couple hours right after surgery. So having a watertight wound is important. And then lastly, yagging early. Don't yag too early. You want to make sure that the patient's happy with the lens, but assuming they're happy with the lens, they're not having too many dysphotopsias, you have a happy patient on your hands. If they come back a month later or 3 months later and they notice their vision's off a little bit, and even if you see subtle PCO, I go ahead and yag them early because it's pretty remarkable so how sensitive the presbyopic IOLs can be to even mild posterior capsular opacification. So early yags, again, not too early, because if you have to do an explant, you want to have an intact bag, but assuming a happy patient, early yagging has been helpful. I think if you do these 4 things, that you're going to be very, very successful as you get started with presbyopic IOLs. Thank you.